move forward. This is entitled IVUS Guided Strategies for PCI and Complex Calcified Lesions. These are my disclosures. And I think we've seen a lot today for those who've been in Hall B, really discussing calcium and so forth. So a lot of this will be reviewed from today. But suffice it to say, calcium, as we know, is a major, major force in interventional cardiology in terms of challenges. We know that anytime there's demonstration of severe calcium, this is associated with poorer outcomes, in this case, all-cause death, both from Horizons AMI and from the 10-year follow-up for the Syntax trial. When there is heavy calcium, we have a 50% increase in all-cause mortality, any particular lesion, and it doesn't matter if you're revascularized by surgery or stenting. So part of this is lesion-based, but also part of this is biology and disease-based when there's heavy calcium in terms of mortality. So why is calcium difficult for PCI? We know this reduces stent expansion. We now have two great risk scores, one based on OCT, one based on IVUS. These have been shown today. I thought this was a nice example that even in the setting of atherectomy, as we increase our calcium burden, we're still going to be limited in terms of our stent expansion. This is 70 to 100 on the y-axis. And I think, we're starting to understand that we can do a better job even with atherectomy, and now we also do have lithotripsy to help us do greater expansion-based work. Why do we want to use IVUS in general? This is driven by multiple randomized trials and very complicated lesion subsets showing that there is an overall 50% reduction in clinical restenosis in left main, CTO, long lesions, all comers. And OCT performs similarly well to IVUS in the opinion study. We'll have the definitive study hopefully soon with Lumium 4 and also Octivus. But the bottom line is that IVUS is doing an important job to reduce restenosis. It's been shown here in Lumium 3 that both IVUS and OCT can improve stent outcomes. Stent expansion and minimum stent area are significantly higher compared to angiography. And it's really, it's remarkable because we don't need to do a lot. The difference between an IVUS-guided MLD, minimal luminal diameter, and an angio-guided is only 0.1 millimeter here. Less than 1.1 millimeter, that's all you really need. But it's the diffuseness, the overall length of the entire stent is also affected. And this is translating into, again, 50% reductions in TVR. SKY algorithm, this was shown earlier. This really recognizes that imaging is vital in calcified lesions. Step one, intravascular imaging. And I think we've seen lots of different algorithms, but the bottom line is if it's not possible to image because we can't get an IVUS or an OCT catheter down the vessel, this is the time to move to more aggressive modification using atherectomy. Here is just a brief example of the importance of understanding calcium, even in total occlusions, where sometimes we're thrilled to have crossed with antegrade true lumen. We can often be faced with non-dilatable lesions that are severely calcified. And sometimes, especially if it's taken a long time to cross, it may take a moment to pause and really take that IVUS out. But in this case, when it's non-dilatable, here you can see the entire vessel has 360 degrees of calcium. It's over more than 5 millimeters. This is definitely asking for rotational atherectomy as the next maneuver. And I should mention this was a retrograde wire true lumen crossing, and we swapped out. And this ultimately led to dilatation and stent deployment. So some other data that IVUS is helpful even in atherectomy comes from the Orbit 2 study, showing the reductions in MACE of about 50% when IVUS was used versus no IVUS. Similar reductions in TLR as the basis of MACE. We did talk about the challenges with calcified nodules. We had some great discussions about this. One careful study, it was published in PLOS One, demonstrated that rotational atherectomy was not particularly helpful for this, probably because the burst slides by and doesn't really engage that calcium when it's a nodule. So we're looking at different mechanisms now for this. People are looking at orbital atherectomy where it's available, and of course lithotripsy does have some opportunities here. Speaking of lithotripsy, this was obviously a critical change in our ability to manage calcium. We know from the Disrupt CAD3 study, it's very effective, 93% success rate, and a very low perforation rate. So really overall, this is, the pooled results of CAD3 and 4 and 5. So IVUS helps us understand how this all works. When we have IVL treated lesions, we can see disruptions in the calcium here, here at 12 o'clock and 7 o'clock, where we get these calcium fragments. These are excellent markers that there's going to be very good expansion to follow. We can test that with a non-compliant balloon and then move on to stenting. I think this was a nice flow chart. We've seen many flow charts. It's very busy. This is one that I think does do a great job because it really incorporates imaging very early on when there's severe calcification. Using our risk scores for either IVUS or OCT, one can then make a decision. If it's uncrossable, of course, we're going to move towards rotational atherectomy and orbital atherectomy. When it's crossable, this first recommendation was to go to lithotripsy, and that is certainly reasonable for lesions that can be treated with one balloon length, for example. And then no mild, moderate calcification. I added my own edit here. I think it's still important to image in these cases. We will certainly still learn about stent sizing, and every now and then what's not appreciated by fluoroscopic calcification can be severe by IVUS. So with that, I'll just again reference the SKY document for those who are interested in the US perspective on complex PCI. And just to conclude, that IVUS-guided PCI of calcified lesions allows optimized choices of atherectomy and IVL devices and device sizing, leading to better stent expansion, which is the foundation for better outcomes. Thank you very much.